in the bed. Something about the blue light isn't conducive to that melatonin cycle. It almost inhibits it. We might ask you to keep a sleep diary for a couple of, because we might ask you, do you remember on average when you go to bed? But then we'll ask you, well, record it, please. What time you went to bed, what time you fell asleep, how many times you got up to the bathroom last night, what time you woke up in the morning, whether you felt well rested, whether you took a nap the next day. Keep that diary for 10 days, something like that, and we'll get a bit of a sense for what's the process in your sleep cycle. Might bring you in for overnight sleep study, a polysomnogram, in which you'll lie in a bed with electrodes on your scalp and picking up your breathing activity and so on, and monitoring the quality and nature of your sleep. And then there's Actigraphy, which is a wearable, kind of like a watch. One of these smartwatches can do the trick. They have apps on it that they'll pick up when you're moving a lot. And if you're moving constantly through the night, you can download that. If you wear your watch during the night, and if you download the pattern, you'll see, oh, I was moving all night. Now, it's natural and normal to move, when you get up, go to the restroom, and so on, and when you're first getting comfortable. But ideally, you'll see long stretches where there's very little physical motion of the actigraph. So the first thing we try to do if somebody's having difficulty with their sleep is to discuss sleep hygiene. Sleep hygiene is just behavioral steps a person can take to set themselves up for, as best as possible sleep. And the elements of that include having a fairly consistent bedtime. Now, the bedtime, for me, bedtime is actually works out best if it's about 9:30. I like to get up real early, go to bed, and if I get a consistency, if I get very variable, because people are guests or stuff like that, it just throws it off. Somebody else's optimal bedtime might be 11, or some people it's 1 a.m. Again, each of us has a different intrinsic pacemaker, and some people are phase shifted, forward or backward, that their optimal sleep-wake time is different from the norm. That's partly why it's tough for teenagers. At that stage of life, the phase cycle is actually often a bit later, and we yet expect them to be up at school at 8 o'clock or something, and all of them. And there's many, regardless, we won't get on to the topic, but you're getting a consistent bedtime that'll fit your cycle. You like to go to bed at 9 or 10 o'clock, whatever it is. Well, try to set yourself up for that as a pattern. No alcohol or caffeine for 6 hours beforehand. Optimize the temperature, humidity, the light, and the noise ambient so that it's comfortable for you. No blue light before bed, no screens in the bedroom. We say your bedroom is for sleep and sex, nothing else. It's not for, so calming mental activity could be reading a book or something of that nature before you go to bed. And then there's mental techniques of relaxation a person can use to choose to learn to, well, counting sheep was obviously a simple one, but there are many others that a psychologist can help a person that fits for them, get their mind in a drift off to sleep state. And certainly allow the sleep to come. Trying to force sleep to come doesn't work out. If it comes, accept it. If it doesn't come, accept that too. It's not helpful to look at the clock and say, okay, am I asleep yet? Oh no, it's still 1 a.m. and I haven't fallen asleep. Actually, best not have the clock there. If it seems that you're laying in bed and there's no sign of sleep coming, a suggestion is to get up, leave the bedroom, go into a different room, get some warm water, warm milk, whatever you like, read a book for a while. It's nice and calming activity like that. When you feel kind of dozy again, then shut it up, go back to bed, and see if sleep comes at that time. But you can't really make sleep come. You try and set it up for allowing it to come. Let's see. Next slide. All right, I said I was going to give a little mini lecture on each of about 8 different topics. The first one I'm going to talk about is restless legs. So restless legs is that sensation people complain of where usually their calves, but it can be their thighs, can be their feet, can be their whole lower body, can be their whole body, but it usually is more in their lower body. That's usually bilateral. It just feels like it's not at peace. It's not at peace. It needs to move. It's kind of antsy, and it feels uncomfortable. If you don't, the only way to relieve it is to move, it seems. You want to work your muscles. You want to get up and pace. That's a classic description. Somebody would say, I'm laying in bed, and my legs just start to feel antsy. If I get up, I pace, they'll start to calm down. I'll go back to bed, and they start to feel antsy again. That's some people describe itchy, creepy crawly, aching, tiredness. Different people have different words for it, but that's the phenomenon. It's usually worse in the evening, and usually when you're resting, when you're trying to get completely relaxed, then when it's going to come and bite you. Now, it's a very common thing in many people, not specifically Parkinson's disease. Depending on how you define it, 8% of people have it. Parkinson's disease certainly have the same 8% as everybody else, but Parkinson's disease also can experience a very similar phenomenon as part of their medication rising and falling. You'll see this coming up again in other parts of my lecture. When your levodopa levels rise and fall, the falling in particular, but probably the rising too, but that dynamic does change the brain state in a way that is not necessarily conducive to sleep. And one of the consequences of the falling dopamine is that the legs can almost feel a withdrawal and feel that restless leg sensation. And people with Parkinson's disease can have that complaint newly developed after Parkinson's disease, after starting medication, particularly if the medication levels are drifting down in the evening time. How do we treat it? Well, we'll look at, if it's from Parkinson's disease context, we'll look at giving continuous dopamine effect. And there are a couple of ways to go about that. There are dopamine agonists, ropinirole, Neupro patch, pramipexole. Those are long-lasting and can be given in the evening and will cover fairly effectively for many people. It can cause side effects too, but that's one option. Then levodopa can be given in more longer duration response if you are wearing off. Another dose before bedtime in like a Rytary formulation or a long-acting formulation, or an infusion. And then gabapentin, pregabalin has a track record for helping that symptom. Next slide. So this ties in with the restless legs. I mentioned that many people with Parkinson's disease taking levodopa have an on and an off cycle. And that is not the way it's supposed to be, frankly. The person without Parkinson's disease doesn't really rise and fall into dopamine to that extent. When we use pills to try to boost your dopamine levels and get them closer to normal, we only give it 3 or 4 times a day, or sometimes 5 or 6 times a day, but the consequence is a rise and fall, that it's not quite natural. And that dynamic can be felt as a wearing off. And that wearing off can be felt, I described the restless legs, but also can be felt as stiffness, tiredness, aching, yawning, sweating, cramping. There's so many experiences an individual can have during the course of the downslide of the dopamine that can feel uncomfortable, unpleasant, and certainly interfere with sleep. So once again, we look for longer acting form of Rytary. We look for extenders like entacapone, rasagiline, dopamine agonist. We might give levodopa around the clock. Instead of giving it 4 times during the day, but taking an 8-hour break overnight, we might add another dose in the middle of the night. So it's every 4 hours around the clock, or sometimes every 3 hours around the clock if somebody's a very short cycling responder. And then there's deep brain stimulation, which can be a more sustained effect to replace the dopamine effect with less in the way of up and down. Next slide, please. All right, I'd like to move. Actually, I could stop and see if there's any questions so far about the first couple of topics I touched on, restless legs, Rem sleep behavior disorder. I've got 6 or 7 other topics to touch on, including behavior disorder. If any other questions, you can stick up a hand and we'll move on. Let me talk about Rem sleep behavior disorder. This is during sleep, somebody acting out their dreams, essentially. Sometimes called Dream Enactment Behavior. And what will happen is during the REM sleep, which, as I said, is mostly in the early morning, but there's a period of it, about an hour after you go to sleep, another period, maybe an hour and a half later, a person can vocalize, can shout, if they're fighting with somebody, can argue with somebody, they can punch, it can be non-directed, because they may be imagining, running away from a tiger or whatever it is, and they'll start running, and it won't be directed. Or, as part of their dream, they can be dreaming they're being attacked, and they'll be striking out, and they'll grab a hold of the nearest thing that seems to be attacking them, which is often their spouse, and they'll try to fight off the spouse because they're dreaming that this body here is attacking them, and it can cause injuries, certainly disrupt sleep. and for both partners. So, and people can be injured, flinging around your, trying to push away the, dog that you're imagining or dreaming is coming at you. You can hit the bedside locker or knock down the Ming vase or whatever it is, and cause injuries of various nature. So what do we do about this dream enactment behavior? Well, make a safe environment. If somebody's falling out of bed, either have a bed that's not too high, consider how far, and what's the nature of the floor. If there's a soft floor, it's going to be better than a hard floor. If you're going to throw yourself out of bed, best to land on a soft floor. It'd be best not have hard edges and bedside lockers and things like that close by where you're liable to hit them. And sleeping separately, that's sometimes the most practical advice. If one spouse is having a lot of this, and it wakes up the partner, then it's probably just as well the partner sleeps in another room. Or at least that's one possible solution. Sleep in another room, another floor of the house even, because it can be kind of loud. Another house if you've got two houses. But there's at least to have, so the partner will get a decent night's sleep. Melatonin is helpful for that. Hard to see exactly why, but research has shown it's partially helpful. It's our first go-to. It's such a mild medication, 3 or 4 or 5 milligrams taken in the evening time, seems to reduce that dream enactment behavior. If you need something stronger, clonazepam, which is a Valium-type drug, that kind of shuts down a lot of nerve activity, including the aggression of the physical activity of the dream enactment behavior. So we'll give you that. But that'll suppress breathing, suppress alertness the next morning, and so on. And it's addictive, and state is monitoring it more and more. So we prefer to not give clonazepam, but if somebody's having a lot of trouble, that's what you got to do. And next slide, please. Then there's obstructive sleep apnea. So you probably have heard of sleep apnea. It's when you pause breathing. Obstructive sleep apnea implies that the problem is that your throat is just kind of collapsing. During sleep, things get kind of relaxed, and these tissues around the throat, and depending on your head position, can narrow enough that it's less airway. In the pharynx, behind the tongue, for example, the tongue may be kind of falling back a bit loosely, and a person's trying to take a breath, and it's, the lungs are expanding, diaphragm going down, and there's negative pressure, but there's not enough airway for the air to move. And the person's running low on air, oxygen. Now, that'll cause an alert response. The brain will detect, it's got all these sensors, carotid bulb and so on, that'll detect your oxygen level is drifting down. And it'll stimulate you to wake up. It'll kind of break through the sleep. It'll cause a person to startle awake. And then when they wake up, they're able to force their mouths to open. They might even sit up or whatever, and they'll gasp for a big breath because they're about, they're low on oxygen. And then they'll get back to sleep again, and the same cycle happens again. And this obviously fragments sleep. It prevents a person getting good sleep. It also, chronically being low on oxygen like that, even just a little low, is probably not ideal. So, obstructive sleep apnea, which is a common problem, more common in people who are overweight, and it's a bit more common in Parkinson's as well, for whatever reason, is interrupts with sleep. What do we do about it? If we identified it with an overnight sleep study, we see that a person wakes up repeatedly in sleep. There are measures for how often is okay to wake up. We monitor the oxygen. If it drops too low too often, we'll count those episodes. We'll have them by certain criteria, yes. The recommendation here is for a mask, a CPAP mask, continuous positive airway pressure, little machine that pumps out air, just air, not oxygen, pumps out air at a certain elevated pressure, and you wear a mask that seals. And that pressure kind of forces the airway to be a little bit open all the time, instead of collapsing and being blocked. So it's effective, but a lot of people don't tolerate it. Anybody tried to wear a CPAP? Anybody tolerating a CPAP, wearing one? And good. And you find you can get used to it, I guess. A person can. Okay, so there's some thumbs up. Anybody tried it and just say, I can't do this? There's got to be somebody, because it's a very common thing for people to have tried the CPAP and say, no way, how can I sleep with that going on? The noise there, this on my face, I can't turn over. Some people just can't get used to it. And in that case, there's not a great solution. I mentioned here, there is surgery that can be taken to debulk the throat. It seems like a fairly drastic measure, but it's one of the things that can be done. An old-fashioned solution I heard of once, and I used to recommend it, but I'm not sure if I ever had a patient who said, hey, that was great, so I quit recommending it. But sewing a tennis ball into the pajama at the back to prevent people lying on their back, kind of if they lay on their back, they encourage them to, oh, that's uncomfortable, and even while they're still asleep, they roll back onto their side, and they're less prone to get the sleep apnea. Somebody told me about that, so I started passing it on, but I'm not even sure it works. All right, painful leg dystonia. So people with Parkinson's disease can experience dystonia. It's one of my fascinations, one of the things I'm interested in. That's a phenomenon in which there's abnormal contraction of muscles. And the basal ganglia, part of the brain that controls movements, that's affected by Parkinson's, a certain type of abnormality in that part of the brain output can result in a dystonia. People with Parkinson's disease certainly can have dystonias. So can people who don't have Parkinson's disease. Dystonias can come on in the early morning, 3, 4, 5 a.m. classically, particularly in a younger onset patient with Parkinson's disease. You're 40-year-old or 45, 50, even 50-year-old. As people are getting older, something about the physiology makes it less prone that it's going to manifest with dystonia. Can do, but just less common. It's usually on the more affected side. The toe will draw up, the foot will draw up. Now, this is a little bit different from Charlie horse. We'll get to in a little while. Muscle cramps are more generalized. Muscle cramps are more in the muscle themselves. That's excitable tissue that stimulate a certain way. Particularly if there's some mild abnormality in the muscle from trauma or something like that, it'll get excited and then it'll just stay excited. Instead of contracting and relaxing when you're done with it, you start to move and contract and it'll stay contracted. That's a muscle cramp. Charlie horse would be tied in with that. That's one set of problems. It's also very common. I think I touched on that later. Dystonia is a bit different. It's coming from the brain. Its output from the nervous system causes sustained drawing that goes on for hours, frankly. It's not like a cramp that might go on for minutes. What do we do about the sustained, painful dystonia? The dopamine effect, a muscle relaxant like baclofen, or Botox injection to the affected muscles. If we inject Botox, it reduces the strength of the contraction, and it just doesn't disrupt sleep so much. So I've got quite a few patients with painful leg dystonia, waking them up at 3 a.m. in the morning, that I'll be able to alleviate the contraction for a few months at a time with an injection. Oh, I mentioned here leg cramps, which are in the muscles themselves rather than a brain output. They can also occur. And there are probably solutions for that include electrolyte balance. Magnesium is one we think of. And maintaining your hydration. Quinine, which is in tonic water. We used to give quinine tablets, but now they're not approved for this use. So quinine in the form of tonic water, a 12-ounce glass of that before bed, probably has your excitability, if you're prone to Charlie horse and cramping, less. Ginger and, there's another one for muscle cramps. Anybody remember? Turmeric, as somebody said, and there's somebody else mentioned another one? Mustard? Yes. Mustard is the one I was thinking of. And again, I'm not sure I've seen any science or trials or things of that nature, but a lot of people swear by it, and so, hey, what's not to like? And I guess, how is that taken? Maybe mustard, mix it in water and drink it?
My wife just mainlines it.
Okay. Cool, okay. But just remember, it's not rubbing the mustard on the leg is what you're trying to accomplish here. All right, let's moving on. Overactive bladder. That's a common problem. So obviously your bladder is a muscle. Your bladder wall is a muscle, and it has a tension, like all muscles. You can stretch it, but the more you stretch it, the more it wants to contract and shorten again. The more you lengthen it, the more it wants to shorten. So it's circumferential, there's muscles go in all directions, so that you constantly make urine from your kidneys into your bladder, stores it, and then when it reaches a certain size of enlargement, the muscle increasingly wants to contract and get it down. You'll feel that. It'll wake you up. You go to the bathroom, empty it down, and start the cycle again. It'll start to build up with urine again, and so on. Now, there's a normal suppression of that reflex. So the bladder wants to get bigger. Children don't suppress that reflex. Once there's any little bit of urine in it, they'll want to contract. With aging, the frontal lobe will kind of develop ways to quiet down that reflex. So you can build your bladder volume and do 3 or 4 hours of whatever you're supposed to be doing and pick a socially appropriate time to go and void and start the cycle again. So that's a healthy, normal process. In elderly people, including people with Parkinson's disease and other conditions that also might affect that frontal lobe in various ways, that suppression less effective, and that bladder reflex becomes more so. If you add on top of that prostate hypertrophy in men, or prolapse or other anatomical changes in women as a result of childbirth or other aging and things like that, it can lead to incontinence, and it can lead to urgency, in which the urge to come will be irrepressible. You'll have to find a restroom real quick, or even not, and you just can't stop it. Let's go. So that sort of overactive bladder is many factors going into it. We just touched on. The volume of water you drink is going to be part of it. But everybody needs water. You need to maintain hydrated. It's important for your kidneys and all the other cells in your body to have enough water. What can you do about it? You can avoid alcohol, which certainly stimulates a nerve activity that produces more urine. Actually, I'm conscious. This is the second time I've been up on the stage. Second time during this short talk. I already said avoid alcohol, and I feel a bit of a hypocrite because, I'm a fan of sleep, I'm a fan of alcohol too, so within limits, within reason. But alcohol does stimulate more production of urine, it just does. Caffeine does too, excess fluids in the evening. And then a habit of voiding regularly enough that there's not much volume building up. There are physical, non-pharmacologic solutions. Catheters, there's indwelling catheters you'd be familiar with, a little tube that goes into the penis, and that could go into a bag, but that's uncomfortable, and it's, questionably whether it's safe in the long term for infection risk and so on. So a condom catheter is all external. It's like a condom with a tube going off the end, and a bag going beside the bed. And that is a workable solution for people with a very overactive bladder and frequency and incontinence during the nighttime. And otherwise, they either have to get up every half an hour to go to the bathroom, or they have to wear protection or sleep in wet, and nobody wants to do that. So this is one solution to allow the urine come out and just divert it. Hard to get one to fit and stay right, but it can be done. There's various models for it. And then in women, there's a Pessary Ring, which is essentially a round rubber, plastic, semi-firm ring, which is inserted in the vagina, which kind of kinks the tissue so that the urethra is less straight, and it's easier to maintain the urine inside and allow them to fill up more. It'll allow you to pee. You have to might position a bit differently to unkink the, but they're simple, physical, safe, non-pharmacologic solutions. Then there's certain drugs. For overactive bladder, we classically use anticholinergic drugs. They block acetylcholine, and Ditropan was the first of those, oxybutynin, Detrol, and then newer ones, Sanctura, Trospium, and there are many of them. They reduce the overactive bladder. They quiet down the nerves activity overacting the bladder. We have become a bit concerned in recent years that these medications affect memory, not just in the short term, but in the long term. So we're not big fans of those anymore. Somebody has to have a lot of trouble and know the solution with their bladder before we'll be enthusiastic about giving those drugs now. There's a newer one called Mergabetron, or Merbetric. That's a different mechanism of action. Works on alpha adrenergic receptors rather than acetylcholine, and we don't think that affects the memory. So we'll use that more liberally without concern about the memory. However, it's very expensive. Then there's a nasal spray called desmopressin that acts on your urine production, your kidney activity is influenced by endocrine output from your hypothalamus. And one of the factors that influences that you can suppress with this nasal spray, desmopressin, and it'll just be an endocrine mechanism to reduce the amount of urine you make. And that can be taken at nighttime. Once again, expensive. Botox to the bladder wall muscle, behind the thing here. You can relax the bladder wall muscle so it's less contractile. Again, it can't get too flabby. You want it, contractile enough, but not too contractile. Tricky thing to do. I don't do that. One of our urology colleagues does. Next slide. I am conscious. I have no idea what time it is. Where are we for time?
About 5 minutes.
Oh, okay. even though we started a bit late. I'm not going to get the extra time. Well, we'll move along then. Depression and anxiety, which is common in humans and common in Parkinson's disease. And that affects the ability to fall asleep, and it causes people to wake up early. And once again, probably a bit of a vicious cycle. If you're depressed, anxious, it's hard to sleep, and then you're more prone to depression and anxiety because you haven't slept. What can we do about it? Well, first thing is the physical, a good daytime activity exercise program. There's no question that helps a person feel good, and not only physically, psychologically, you're doing something, but the endorphins and various other factors that come from physical activity. Social engagement we think is good, and then there's mindfulness, coping, imaging strategies, art strategies can help people with depression, anxiety to get to a better place, let's say, mentally. And then, of course, there's medications. And probably the first medication we think of in Parkinson's disease for depression and anxiety is Zoloft. It's not the only one. There's vast numbers, Paxil, Effexor, whatever you're having yourself, Remeron, so on. So lots of antidepressant class medications. Risks and benefits with various ones depending on what other medication you're taking. Next slide, please. And finally, I was just going to touch on the sleeping pills that we use. Well, I briefly mentioned the antidepressant class medications. These are more focused on sleep. So melatonin is not a prescription, it's over the counter, and it's a natural thing. I've never heard of anybody getting side effects. There probably have been people who got side effects, I've just never heard of them. And it's a very bland, benign thing. It doesn't have a huge effect. It's not going to put you to sleep. But if you take it consistently, many people find their sleep-wake cycle is more regular and more rewarding. Again, I wouldn't expect miracles, but melatonin is a standard, proper thing to do. It's reduced in Parkinson's disease, and taking it on a consistent basis. And again, I don't think a mega dose is better than a lower dose. I don't think so. Where do we go? Very good. Okay, we got the mid-screen. It's even better. Then, if somebody if we do all the above, and somebody says, I just can't fall asleep. It's not this, it's not that, I just can't fall asleep. And we try psychology things, sleep hygiene, and they say, Doc, give me something to make me go to sleep. Probably where we'll start would be Trazadone. That's a very old drug. It's got a long history of safety and efficacy, including in seniors, and so it's a go-to drug. We start at 25 milligrams, may go higher and higher. It's taken at nighttime. The more you take, the more effective it is, but the more you'll hang over the next day. So we're trying to get there's no pill that you take it at 10 o'clock, takes effect then, and it's gone by, it stays through the night and it's gone by 7 a.m. in the morning. There's no pill that does that. They all have effects that rise and then fade away with the tail that goes on for many, many, many hours into the next day. So you try and get one that the tail is going to be, and take a dose that the tail is going to be low enough when you want to get up at 8, 9, 10 in the morning. But that means you're going to have a low enough dose that you won't get a great effect early in the night too, or through the night. It's a trade-off. Remeron or mirtazapine is another medication that's antidepressant class drug. It seems to be quite effective for mood and sleep in people with Parkinson's disease. Then there's the classic sleeping pills. Ambien, you'd know the brand name of, Lunest, so on. They'd be prescription sleeping pills. All those drugs, of course, have been associated recently with dream behaviors like sleepwalking and things like that, going to the fridge, eating, things like that. But they also are quite effective for helping people go to sleep. Biggest problem is if you take it a number of days in a row, very hard to go to sleep without it. You have you go through a withdrawal almost of finding it hard to sleep. And some people say, well, I'll never stop taking it. I'll take it now, the rest of my life, and maybe that's a healthy thing to do. It's not necessarily a terrible idea, but you question whether it's a great idea either. But if you take it for a long time, you may have to go through days or even a week or two of poor sleep as your body is resetting to be able to try to sleep without it. There's a new one called Besomra that probably has it does have a different mechanism of action and probably has a role in Parkinson's disease. It's a bit too new for me to have enough experience to be able to tell you that it works great or not, but I kind of like the concept. It works on orexin and I think it's going to be a good drug. I mean, it has been around for a couple of years now, I think, but it's fairly expensive. I haven't built up a huge track record with it yet to know. Then there's the benzodiazepines, classic Valium-type drugs. Clonazepam is probably the most common one we use, but of course there's various benzodiazepines, Xanax, and those are tranquilizers, and they'll tranquilize you, put you to sleep, and make you drowsy, but they have a tail. And the more you take, the bigger the high and the longer the tail. So you have to take a low enough dose that you're not hungover the next day. That may or may not help you. Once again, you'll be dependent on it, and it'll suppress breathing and memory a bit and balance a bit if you have to get up during the night. And finally, there's the major tranquilizer, so-called Seroquel, which is a brand name for quetiapine, Zyprexa, which is a brand name for olanzapine, would be drugs of that class. And they can be very sedating. They were initially designed to calm agitated people down, including people with psychosis, schizophrenia, things of that nature. We have found that they can have a role in people with hallucinations as part of Parkinson's disease, and they are sedating as well. So if somebody's got that combination of pretty bad hallucinations and pretty bad insomnia, we'll look at Seroquel, for example, in the evening time to have that dual effect. Our concerns are always excess sedation, hangover, sleep apnea, and dependence. I think that's my last slide. Go ahead, next slide. Yeah, it is, back to the beginning. Have we time for questions, Mike, or are we done?
Let's see if there are some questions, and we'll take a few minutes.
All right. Does anybody have questions about that topic I ran through fairly quickly here about Parkinson's and sleep?
If there are some questions, let me come to you. And the reason is because we are live streaming, and the only way they will hear the question is if you speak into the mic. So right here.
Doctor, could you speak a little more about using a CPAP machine?
All right, so CPAP machine, turn it on. You have to be fitted for it to, fit including your beard and the nose and the shape of your face, and that has enough seal but not be suffocating. And then a doctor in the sleep lab adjusts the pressure. He tries, how about 7, how about 8, how about 9 setting, and he'll see what'll maintain your sleep with as little sleep apnea overnight, as little arousals overnight, as little drop of oxygen with the lowest setting of oxygen that you can get. And people who can tolerate that, they take it home and they by the bedside, and they put on the mask each night before they go to bed, and they strap it on and seal the space here. They flip the switch and they lay in bed, and when sleep comes, this maintains their pressure and the airways being open so they don't drop during the night. There's new ones now where it just goes in the nose, because some people find that, but you have to seal the mouth. I'm not sure exactly why that's an advantage, but there are various ways to try and get around people who don't like it. But still, a lot of people just don't like it.
Yeah, thank you.
Does the blue light effect have more to do with going to sleep versus staying asleep?
Going to sleep, I believe that the computer screens, they're at a frequency, don't quote me on this, 700 or 600, and so, I can't remember what it is, but it's a frequency that, a lot of research on animals and humans, that light at that frequency suppresses melatonin. You want your melatonin to be allowed to rise in coming into 6, 7, 8, 9 p.m. at night and hitting a peak around 9, 10. And if you're exposed to computer screens during those hours, it'll inhibit that optic pathway going to here, particularly at the high frequency. Lower frequency, 500 hertz or something like that, or I can't remember the units, is less suppressing of the melatonin and therefore the sleep ability. So again, we recommend no computers in the hours before sleep, no screens. Again, a lot of people say, well, I need to catch up, check my email, whatever it is, watch, that's life. But if it's a big enough problem for you, I guess you find a way to avoid screens at that time of the night.
Okay. My question was, could you elaborate a little bit more on the medications that help with the severe cramping that lasts more than just a few minutes?
So muscles for the cramping, you're asking. Okay, so painful cramping, we try and get a sense of whether it's a brain nerve activity dystonia, and if that's the case, we'll often look at baclofen as the first line. That's usually taken at nighttime, and you take a dose that we hope will carry it through the night. So that's if it's a brain level activity. If you think it's a Charlie horse muscle cramp, we'll start with the more natural things. And mustard was one of the ones mentioned. And magnesium, quinine, things of that nature. And if somebody needs a pharmacologic treatment, well, actually, there's not a great drug, and I don't like the idea of just throwing drugs and seeing what happens. There's not a good, proven, effective solution if these other solutions don't work. I guess Botox, because it's relatively safe, it doesn't affect your whole brain, your whole body. I often think of that if somebody's got bad enough painful cramping. Pretty expensive, though.
I see that hand.
Okay, my question is regarding Botox injections. So I've had, I think, a round of 3 or 4 different types of Botox injections for my dystonia, and they've not worked. So I don't know if it's a dosage thing or if it's just they don't work on me, but they have not helped my my drop foot. Well, I call it drop foot, but it's a dystonic.
Did you say drop foot?
Yes. But it's not really drop foot because they've tested and I have strength in my foot. It's really dystonic.
Okay. Assuming that dystonia is the problem, then, and from a nerve telling the muscle to overcontract, enough Botox into the right muscle should work. So there are 3 things that could have gone wrong. First of all, it may not just be simply dystonia. There may be something about, affecting the nerve. I don't know enough about your individual case to try and comment on that, but it may not be simply dystonia. It may not be getting enough units to weaken the muscle, or it may not be going to quite the right places. And it doesn't, certainly a number of patients that I inject, it doesn't seem to work out. And I don't know which of those things it is. It's kind of tricky to get the right amount in the right places. That may be part of it.
Any other questions? All right. Dr. Sullivan, thank you so much.
Sure, happy to do it.
And we have a little something. It is.
Thank you.
I want to give you.
Thanks so much.
Thank you.
Bye, Mike. Have a good rest of the day. Thank you.
All right. We've gotten a little behind schedule. That is okay. What that tells me is that your breakout sessions were good. You hung around, you had some questions and good things there, and we allowed some questions here. What we want to do now is we want to draw for these baskets and do that, and then we're going to have our last session, and if it runs over a little, that's okay as well. If you need to leave, that's okay. So bring the basket up, and my assistants here, this is my wife. This is the DAPS office manager. So my wife, Donna, and our office manager, Andrea. So I'm going to let one of you. All right, let's see what we got here. Okay, it looks like Barry Kleckner. Am I saying that right? All right, Barry, congratulations. All right, I have a Don Markle. So Don, all right. Okay. Gianna, and it looks like the last name is Hisbus, Gianna? Jeannie Huber. That's it. That's it. Pardon my inability to read. All righty. Well, thank you all for getting around to our sponsors and making that a successful event as well. And now it's my pleasure to introduce Dr. Lsvt. She is an associate professor of the Department of Communication Sciences and Disorders at the Texas Women's University. She received her master's degree in applied cognition and neuroscience and a PhD in communication sciences and disorders from the University of Texas at Dallas. Her primary research interests reside in the areas of voice-speech production, motor speech disorders, neurogenic communication disorders, and her current study focus is on voice remediation, voice-related quality of life for individuals with Parkinson's. So join me in welcoming Dr. Lsvt. All righty. And they have you wired, so you don't
Okay.
need that.
Can you hear me? Thank you very much for nice introduction, Mike. It sounded a little bigger than I am, but let's try. Okay, so my slide. Everybody has the handout? Yes? If not, there's one extra. Everybody has? All right. Would you get my slide? While waiting, let's stretch a little bit. Isn't that nice after lunch, after learning so many things? Yes? All right. Okay. Are we getting there in the back? Okay. Let's give them a second. Okay, before the slide set comes out, let's talk about that. We like to move around, right? So today's symposium is also keep moving, okay? And then sometimes we don't consider that speech as movement, but it is. So that's what I will start from today. So we are looking at this nice family pictures, baking cookies, and grandparents talking. So when we are talking, we don't think about our voice or speech because it's always there with you, right? And then if you cannot move, then you recognize immediately. But the voice, until you lose it, you don't care about it. At the same time, you talk about, I don't like him because his voice is weird or something. So voice represents personality or yourself. Oops, it went out again. So I will show you the speech is a type of movement first. When the slide comes back. Oh, it does. Okay. Okay, now I am showing the speaker and listener. Speaker on the left and the listener on the right. So speaker will first come up with what to talk about. Yes? All right. And then say, for example, okay, may I have a glass of water? Okay. And then when he says that, then that will be speech signal. Okay. Waveform comes out from his mouth and then go to the speaker's ears. So speaker knows what he is talking about. And then listener knows, okay, I got it. And then listener's brain will interpret, okay, this guy would like to have a glass of water. All right. So we are repeating this process. And then at this point, may I have a glass of water? When he says that, speaker says that, that's a movement. A movement sounds like, but that really, a lot of movements. So we will talk about what I'm talking about, the movements. There are 3 areas we need to move to get our voice out. First of all, that's a respiration. Do we talk when we breathe out or in? I'm asking you if you talk like, I am hungry, or I am hungry. Of course, the latter. So we breathe out, and then voice comes out, not breathe in, right? So first, you need to get the energy source into your lungs. And then when that comes out, that will give the breath support, energy to speak. So receiving that, we have the vocal for that right here. So I brought my friend, we know larynx. In there, we have vocal folds, and that needs to vibrate. Okay, so many times. And then at this level, the voice is only buzzer-like sound like this. Not speech. And then after making the source sound, then we use the articulators like tongue and jaw and chin and stuff, and they shape up our speech sounds. So speech involves a lot of movements. Okay, oops, came back here. So let's talk one at a time. Respiration is the first subsystem to enable us to talk. Okay, so I am showing different postures. Not only Parkinson's disease. With the age, our postural support get lost. Sometimes I go to the classroom, and then I carry my textbook and walking, and then glass door, I see an old woman carrying the same textbook, and then somehow very bad posture. I said, oh, somebody's teaching the same course as I do. What a bad posture. And then look at that with my glasses. Oh, it's me. So those things happen. So it's not only Parkinson's disease, but now we need to be aware. So the air comes out from the lungs to support our voice, right? When we get the drink out with a straight straw and then fan straw, which one is easier to drink a lot of stuff? Of course, straight. Because if it's not straight, there are a lot of trouble, like left and right, and finally go to your mouth, and you can get the juice or something in summertime. So the same is true. If the posture is like that, air doesn't come out to support our speech, right? We need to wait until this fan straw-like posture for air to come out. So we need to be careful about the posture. Posture affects our breathing. I am showing two different types of breathing. On the left, you see the shoulders are moving. And then diaphragm, which is the dome-like structure that separates our chest cavity and abdomen. That's not moving so much. But the right one, shoulders are stable, and then diaphragm is moving. Okay? That could be two different kind of breathing patterns. So the left one is so-called clavicular breathing. So when I see voice client, the first thing I see is how the person is breathing. And then oftentimes I see, we need to fix that. We like to have thoracic or diaphragmatic breathing. Thoracic, I see the movement more like front and back on the chest cavity. And diaphragmatic, I see the breathing, the tummy goes out. That's the most effective one. So either way is fine, but I like to see the breathing pattern look like the left side. I mean, right side, I'm sorry. Okay. So these are bad and good breathing for speech. Okay. Let's try a little bit of exercise. I'm not a PT, so I cannot fix your posture completely, but there's a way. So if you like, you can get up or you can sit up. So hands out. Do it with me. Okay? So palms are up, and then you gradually get your two hands meet in the middle. Okay? So if left and right hand together, and then you look at that, are your hands pointing the ceiling? That's a good sign. But if your posture is not great, not like that, your hands go like this. And you see your two hands are pointing that way, diagonal. And then if that's the case, well, most likely many of you are, so that's fine. Then you gradually bring the hands up toward the ceiling. Gentle and slowly. And then you get your hands quietly down. So that's the good airflow for speech. Instead of, it's really difficult to talk, right? So it's easy way. You feel like, oh, my voice is fading. Let's check my air. Then you can go like this. And if that, then you go. All right? And also, how many times you breathe per minute? that affects your voice. So I will ask you to count how many times you breathe. I will take the time, and then what I want you to do is, you don't go like, one. You don't do that. Just naturally breathe in and out, like 1, 2, and then hopefully from the nose. Okay? So I will ask you to start, and then you start counting how many times you breathe. All right? So are you ready? Yeah. Okay. Ready, set, go. My case. Stop. So how many times did you breathe in and out? How many times? If it's between more than 10 times or less, raise your hand. Nobody. Oh, 2 people. Okay. So 15 times, between 10 and 15 times, raise your hand. Okay. Between 16 and 20, raise your hand. More than 21, raise your hand. That's a good group. Sometimes I have some people breathe more than 21 times. So what happens is the average is, it depends on the book you see. So some people say different numbers, but voice-wise, if your breathing is 19 times or less, you can manage it. But if you are more than 20 times, then your speech go like that because you have to breathe so many times and then your speech is not connected. Okay? So we need to fix that. But you don't have to. You are fine. All right. That's the good news. Okay. So let's talk about the phonation now. So phonation, I am showing beautiful lady, and then we see her larynx in there. We all have this in our neck. This one is, of course, a big one. Mine is not that big, but it's easy to see. So this is trachea. Under that, we have lungs. So I'm not showing only this larynx area. Okay, so in the larynx, we have, if you slice the larynx in the frontal way, cut in this way. Don't cut me, but cut in this way. You see that slice. In that slice, this area are the vocal folds, left and right, 2 things. And then if I look at that, magnify that, when I'm talking, like then my vocal folds are moving. Come to the midline, and then apart. Come to the midline, and then apart. If I look at that overhead, then I will see this movement. This looks very, very gracious. Slow movement, but the fact is, for males, on average, vocal folds come to the midline and apart 100 to 150 times per second. And for females, 180 times to 250 times per second. So it's really busy. Just to talk a little bit, we are moving, lungs and vocal folds, and now we talk the third one before too long. So a lot of things are moving. Okay, if the vocal folds don't come to the midline, what will happen? There's a gap. Okay? When vocal folds come to the not complete midline, for some reasons, maybe with Parkinson's disease, all the movement amplitude gets smaller. So maybe the air from the lungs may be not strong enough. we call as subglottal pressure, or maybe vocal folds cannot move enough and then can't come to the midline. Then what happens is air leaks between two vocal folds. So the voice like that, because my vocal fold cannot come to the midline. So I have breathy voice. And then when I have breathy voice, I would like to get my communication through, so I kind of more effortful. And then you talk like this. And then even though I get more effort, then people don't hear me. Does it sound familiar? Yeah. Okay. So now I am showing some other reasons people's voice become breathy or hoarse. Not only Parkinson's. Well, I see a lot of clients who have Parkinson's disease and then many others. Many strokes or some other blood pressure issues or sometimes vocal folds pathology. Well, if you have laryngeal cancer, something may block two vocal folds come together, and then cyst, something might growth come up from inside the tissue. That could get the vocal fold puffy and can close completely. Blech. And then this one is still the beginning phase of cancer, carcinoma in situ. It's not spreading, but stage 0 cancer, so-called. And then vocal fold nodules, there are many possible reasons. And then before you go to the voice therapy sessions, you like to rule out those things. So I suggest you, it's very important for you to go see otolaryngologist before you start the voice therapy. So otolaryngologist takes care of the larynx, and then we, including myself, speech language pathologists take care of your voice, but not the tissues. All right? So otolaryngologists may sound unfamiliar. You know ENT, but not really otolaryngologist guys. Let's think about that. When your teeth are not straight, who do you see? Orthodontist, right? You don't go to general dentist to straighten your teeth. Because you know that orthodontists are a special type of dentists who train to straighten your alignment. Well, similarly, ENT is the general ear, nose, throat doctors. Otolaryngologist has extensive training to specialize in the larynx. So whenever possible, it's a good idea to see otolaryngologist. Okay? So that's what I want you to do before you start the voice therapy. Whoever I see, I always ask, visit otolaryngologist and make sure, rule out vocal fold tissue pathology. Then let's begin. That's important. Okay, so I have a question. So somebody said that, I don't understand you. Would you say it again? Well, probably you are nice enough to say it again. But when you say it again, can you change the way you talk? For example, when I say, I'm hungry, and somebody say it again, and then can I say, I am hungry, or say it again as, I'm hungry. The same thing? Possibly, you guys do the same way. You don't change anything. Because Parkinson's disease, not only the movement disorders, but also sensory system is a little disturbed. So you don't know what you're doing. You feel like you're talking normally, but you're not understood. So you repeat the same way. If that's the case, you need to think a little more. Okay? Well, what you think is normal volume of speech may be too quiet. So you feel like you're shouting, maybe normal for the listeners. Okay? If you have a doubt, you might like to record your speech. Okay? So I'm talking normally and then record on the iPhone or something and listen. Maybe you'll be surprised to see such a small voice, like, possibly. Okay? So here is the treatment. You often hear about Lsvt. That's a Lee Silverman Voice Treatment Program. That is the most commonly used Parkinson's disease voice remediation program, the best, most researched. There are many others. Okay, I'm not saying this is the only one. There are many other programs, and then no one program fits for everybody. As you know, Parkinson's disease presents with many different ways. Yours is different from yours, and from yours, they're unique. So voice program is the same thing. So I cannot guarantee Lsvt can take care of everything. Okay? But this is a good example to see how the voice can change pre and post-treatment. So let's look at that. Would you please play this video clip in the back? I think I cannot do it.
For your voice that you would associate with Parkinson's?
Yes, I don't speak loud enough a lot of times.
Anything else?
Hoarse.
Uh-huh. Anything else?
I stutter, which I never did before.
Do this for me if you would. Take a deep breath and say ah for as long as you can.
Ah.
Good for you. Okay. Would you say Parkinson's disease has caused you to talk less?
Yes,
Because?
because I stutter and then I can't be heard. If there's noise in the house, like when the kids come over, nobody pays attention to it because they can't hear me. Till I get mad and then yell.
Take a deep
After
breath and
treatment.
say ah for as long as you can. Have you noticed changes in your speech or your voice as a result of the speech therapy?
Oh, yes.
What have you noticed?
I talk louder. I think louder. I'm going to sing with the Sons of the Pioneers one of these days with my voice.
Good for you. That's excellent. What practicing do you do at home?
My ahs, my highs, and my lows. And I read out the mail out loud.
Excellent. Do you feel like practicing helps?
Oh, yes.
Okay. Do you feel as though people can understand you all of the time now?
Majority of the time, unless it's my husband, and he'll say, "What? I can't hear you."
Good for you.
But I think he does that just to be cute.
I think he does too. Has anyone commented that it's easier to understand you now?
Oh, yes, I set some of our friends back when we went to their house and I talked loud. Lou says, "What the hell happened to you?" My daughter said, "Oh, Ma, that's you?"
Isn't that good? Don't you feel wonderful?
Oh, yeah, because now she can't say, "I didn't understand what you said."
Right? No excuses, right?
Yeah,
That's
no
right.
excuses.
All right. So what do you do when you want to be as easy to understand as possible?
Think loud.
Okay, so it gives us hope, isn't it? So if the problem is only Parkinson's disease, then Lsvt is very effective. And then some other program too. I am not pushing this one program. All right, so after that, let's try exercise 2. She said ah, so let's try big ah, right? Okay, so I don't want you to breathe in from your mouth because if you have blood pressure problem, like after that, sometimes you feel like. So don't do that. So breathing from the nose as much as you can do with big ah. Let's try. Ready? With me. Ready? Ah. Fantastic. Do that as your exercise. Now, we will do low to high as she indicated. So low to high is, in English, we like to have some intonation. And then another problem with Parkinson's speech is You guys tend to become monotone. I am hungry. We like to say, I am hungry. Those up and down. So we need to have intonation change. So let's practice with ah. So we will go from lowest pitch to highest pitch. So let me show you. Ah. Do what I did. Ready? Nice. Let's do the reverse. High to low. So let's go like this. Ah. Ready? Ready, set, go. Like that. That's a simple practice. You know, all these are good sports players, basketball players. Still, they need to jog and stretch and stop. So we need to do this kind of thing. Okay? Voice practice sounds a little bit silly, and you don't want to be seen by others sometimes. Yes, I sometimes teach 6 hours a day, and then I don't have voice disorder, but I need to train my voice. So when I'm driving from Dallas to Denton, I do it by myself. Nobody's listening like, ah, ah, ah. And then sometimes using straw and then phonation. Please do that. We need to use or lose. Okay. So now I will talk about articulation. So finally, after making this good source sound, over here at the vocal fold level, we need to be able to make speech sound. So let's look at this video clip. Would you please play that one?
Wish to know all about my grandfather. Well, he is nearly 93 years old. He dresses himself in an ancient black frock coat, usually minus several buttons. Yet he still thinks as swiftly as ever. A long, flowing beard clings to his chin, giving those who observe him a pronounced feeling of the utmost respect. When he speaks, his voice is just a bit cracked and quivers a trifle. Twice each day he plays skillfully and with zest upon our small organ. Except in the winter, when the ooze or snow or ice prevents, he slowly takes a short walk in the open air each day. We have often urged him to walk more and smoke less, but he always answers, banana oil. Grandfather likes to be modern in his language.
We saw a lot of movement, didn't we? So some sound, the tongue is up. Some sound, tongue is kind of, backwise, moving to the back and then big hole between. So we do this. So this speech we just saw, the video clip is less than 1 minute. And then in 1 minute, there are so many speech sounds made. This guy was not too fast talker, just normal. But more than 8 speech sounds come within 1 second, each second. So that's what we are doing when we are talking. So that's a lot of movements. And then also another thing I talked about, the coordination of the breathing and the phonation and articulation. That needs to come together. When this guy talked, each sentence or each phrase, he doesn't have any extra air. So when I count 1, 2, 3, after I say 1, 2, 3, I don't have any extra air. I don't say like 1, 2, 3, I don't have it. I use up all the air I come out with 3 numbers. When I count 4 numbers, then I say 1, 2, 3, 4. And after I say 4, I don't have extra air left in me. I don't go 1, 2, 3, 4. I don't usually, unless I plan to. Okay? So it is very interesting coordination of respiration, phonation, and articulation going on when we talk. Now let's try exercise number 3. So we will count from numbers 1 to 10, but after 5, we breathe in. So the first breathe in air, we will use up with 1, 2, 3, 4, 5. And then we breathe in from nose, and then 6, 7, 8, 9, 10. Let's try, as everybody can hear, even hear out of the church, okay? Big voice. Ready? 1, 2, 3, 4, 5. Breathe in. 6, 7, 8, 9, 10. So speak like that. That's fantastic. Great job. Okay, so this is my story about three subsystems for speech production. And then voice therapy could be indirect and then direct. So indirect one does not have anything for you to say anything. Like this, posture adjustment, you didn't say anything. That's indirect. And then direct one can be divided into non-conversational tasks such as or and then conversation, some words involved, okay? So which one we like most probably is you want to go to conversation. But non-conversation is very important, basic exercise. And then indirect one, posture is the preparation for good speech production, okay? So this is a story of speech. And then I like to talk about swallowing. Is that okay? All right. So swallowing, I am showing the structure, our structure. So we have vocal fold and trachea, and then go to the lung. When we breathe in and out or speak in and out, the air comes in and then out, in and out. So behind that, we have digestive way. So this is a flat two-dimensional diagram. So it looks like the airway and digestive way are next to each other. But actually, digestive way is right behind that, okay? So we have some common areas, throat areas, share for speech production and the swallowing. Okay, so swallowing, this is a big tongue structure. When we stick our tongue, we feel tongue is just a little bit, but tongue is a big body. At the end of the tongue, we have something called epiglottis, tiny little structure, like a mini tongue. And then this guy flips over to cover the airway when we eat or drink, so that the material will slip into the digestive way. Okay? So this is a normal swallowing. Look at the yellow thing go in. Hey. So go in, epiglottis flip, and then the yellow thing went to the digestive way safely. No droppage for the airway. That's a good case. So the other one is the abnormal swallow. Okay? So the same structure, but let's see how it goes. Drink. Whoops, something dropped to the airway. Look at that. Wow. That's a bad thing. Okay? So I will show you in this X-ray picture we call as MBSS or VFSS. Doctors call differently. So this is an X-ray swallowing study. To orient you, this is the upper and lower teeth and chin, and then the neck. The same is true. And then front side is the airway, and then one behind that is the digestive way. So we hope that all the food go to the digestive way without dropping to the airway. Okay? So the left one is a normal, and then the right one is abnormal. Let's look at that. Would you play that? So it went to the digestive way. Uh-oh, leak to the airway. Did you see that? All right. So now, can you feel your food going to the airway when it happens? I do most of the time. When I drink the water and the water goes to my airway, I know that. And then what do? And I get it out to protect my airway. Can you cough to get it out of the airway? Many times it doesn't happen with Parkinson's disease. As I said, sensory awareness is disturbed as well as the movement. So sometimes you don't know what's going on. That's the dangerous thing. So silent penetration and then silent aspiration. If you don't know the food went to the airway and then you can't cough it out, then the lucky case is penetration. So the food or something, drinks, stay above the vocal fold level. And then unlucky case, aspiration. Food or drinks go under the vocal fold level. then that will go to the airway. We all can sustain, we don't die immediately if something goes to the airway, a little bit. But if you keep dropping the stuff into the airway, and then that material resides in the airway, meet bacteria or virus, what will happen? Then infection happens. And the scary thing is called aspiration pneumonia. That's a major health risk of the people with Parkinson's disease. And then some people feel like, well, I don't have any swallowing problem because I don't feel it. That may not be true. So you need to be very careful with silent. Without your knowledge, food or drinks go to your airway. Okay, so sensational movement. We talked about speaking and swallowing. Share the structure of a completely different action. When we speak out, we breathe out, and then the voice comes out. Breathe in and voice come out? No. Usually, no, we don't do that. It's not comfortable. We don't do that. Okay? However, when you swallow, things go inside. And then when you swallow, moment of the time, you stop breathing. When you go gulp, you don't breathe in and out. No, stop it. Just tiny little bit. So even the same structure, we use very differently. Sometimes some people feel like voice therapy, and then I can talk well, and then I think all my swallowing difficulty is gone. I'm not sure, because your sensory system may not be sharp enough. So if your voice is still wet, quality, or you feel like, I don't think swallowing problem, but something is somewhere in this area, then it's a good idea to check with your doctor for image study. So we depend on sensory awareness for every movement we make. For example, if I decide to move to mic, okay, I like to walk to mic, and then I need to depend on my sensory system, my visual system, and see the steps. If I don't depend on that, I keep moving, I fall down, right? So sensory system is very important guidance for every movement we make. So if the sensory awareness is not sharp enough, then it is very dangerous for you, especially for swallowing. Okay, to summarize what I talked about, it's a little over time, but I started late, forgive me. So daily effort about the speech and voice, daily effort can improve the breathing, vocal fold movements, and articulation. So we need to use or lose. Okay, we need to keep using. If you look at the dog, old dog and the young dog, see the full moon, they all go, woo. We cannot tell. But human beings, as we get older, we speak less. Because we retire, we stay home, we have no reason to keep talking. But make the reason. Make the movements so that you can keep talking. If your movement is disturbed, if you cannot move, more so you need voice and speech because you need to, pass your request or command to others to help you. If you cannot move and if you cannot talk, that is very inconvenient for you. So don't wait until your voice is gone. Kodak moment, I will wait if you like to. But you have the handout, right? But if you like to have Kodak moment, yes? Go ahead. Okay. So no one method fits all. Consult with speech-language pathologists because usually we have many tools. And then when you see the clinician, I want you to be able to meet the clinicians who have many different methods on the belt. So when you have a handyman or carpenter, would you like to go with somebody with one tool on the tool belt or many of them on the tool belt? Of course, we'd like to have somebody who has many tools on the tool belt. So that means a speech-language pathologist who knows, who are trained in many different methods. Well, Parkinson's disease, everybody is different. And then if speech-language pathologists have many methods on the tool belt, then she or he can customize the therapy for your needs. That's very important. Okay. Do you have any questions for me? Yes.
Let me take the mic.
Oh, surely.
heard a speaker one time who talked about the procedure. Okay. I have a question regarding the vocal cords not closing.
Still, it's not on. The microphone is not on.
Here's another one. Okay, here comes a new mic.
Oh. We will hear.
Because we're streaming, we want everyone else to be able to hear this. So.
Okay, can you hear me now?
Yes, I can.
I have a question regarding the vocal cords not closing. One time we heard a speaker from TCU who talked about a procedure to kind of plump up the vocal cords so they will close. It sounded almost like a Botox method, but I've never heard other people talk about that. So I wanted to know, is there such a procedure?
Okay, so the question is vocal folds not closing completely. She has heard from TCU clinician that some augmented procedure to fill the unclosed areas. Okay, so my answer is there are two reasons vocal fold cannot close. So one reason is, well, three reasons. So the first reason is the subglottal pressure, the pressure coming from your lung, is insufficient. So if you have something too, and then you go, maybe it's not enough. You like to have certain strength of the pressure. Okay? So maybe that's the reason why. Many times that's the reason for Parkinson's patients. Number two, you have something developed, like I showed, nodule or something. Something is in there, then you cannot come because of the obstacle. Okay? Number three reason is something called vocal fold bowing. So let's assume my two legs are vocal fold. Okay? So I can close like this. Okay? But if I have both leg, always the gap is in there. So then air leaks. So if the structure is like this, then never you can expect to close. Then they do augmented procedure to put something and then kind of puff up the vocal fold so that it's near straight and then come together. So that's what they were talking about. But most of the Parkinson's case is the pressure. So loud and then breathe better, and then vocal fold will come together, like the lady, Lsvt lady we have watched.
Well,
Did I?
Which doctor does that in this area?
So that is, you need to go to otolaryngologist and the vocal fold observation. So there's an endoscopy, probably there are two endoscopies. One goes from the mouth, but the other one goes from the nasal tract. That's flexible, it's not hurting. And then go there, and then there's a mirror showing the vocal fold. So that doctor can see, oh, okay, the tissue is good. And then probably this is because of the pressure problem. Or, oh, I see the bowed vocal fold. Probably that's a structure problem. Then structure needs to be fixed to be functional. So you need to go to otolaryngologist if you think your vocal fold has limitation. Whatever you do, the structure limits from closing completely.
Thank you.
Okay. Any other questions? No? Ready to go home? All right. Thank you very much for listening.
Dr. Lsvt, thank you very, very much. And we have a little something for you. So thank you. Thank you. All right. Thank you one and all for coming. And one last favor I'm going to ask of you. Watch your emails, because if you registered, we're going to be sending you by email a chance to evaluate the day. And so your feedback will help us as we plan for next year. So thank you. Enjoy the rest of your day. And I hope today you learned some things that will help you.